So the purpose of this lecture is to provide aspiring surgical technologists with a better understanding of antibiotics and antimicrobial therapy. By the end of this lecture, you should be able to define terms and recognize abbreviations associated with antibiotics and antimicrobial therapy. You should also be able to discuss the term antimicrobial and the categories and agents that it's associated with. Also, you should be able to define, explain, and distinguish between hospital-associated infections and surgical site infections. In addition to that, you should be able to state the purpose of antibiotic therapy in surgery. After this lecture, you should also be able to identify and discuss the various ways in which antimicrobials work. But wait, if you order now, there is more. You will also have the ability to explain antibiotic resistance, as well as discuss common categories of antibiotics that are used in surgery and provide examples of each. I am super excited to help you achieve these objectives. Let's get started, shall we? Over the next several lectures, we will be learning about several categories of medications that are routinely used in surgery. In surgery, medications are necessary and they're varied. Remembering the names of all of these medications and what they do is often a struggle for students. So I suggest using drug cards. These are a very helpful, easy way to help you learn drug information. At one time, it was unknown that bacteria were responsible for causing wound infections, and because of this, many people died. Over time, we have come to understand more about bacteria and the role they play in surgical wound infections. This gave way to the development of today's aseptic practices that we refer to as sterile technique. So this, coupled with the development of antimicrobial agents, have dramatically reduced the number of surgical wound infections and as a result have saved many lives. Unfortunately, several bacterial species have become resistant to these antimicrobial agents, and sadly, surgical wound infections are on the rise. According to the CDC, there were approximately 114,124 surgical site infections associated with inpatient surgeries only in 2021, which was a 3% increase up from 2015. While advances have made infection control practices, including improved operating room ventilation, sterilization methods, barriers, surgical technique, and the availability of antimicrobial prophylaxis, surgical site infections remain a substantial cause of morbidity, prolonged hospitalization, and death. It's reported that surgical site infections account for 20% of all hospital-associated infections and is associated with 2 to 11-fold increase in the risk of mortality, with 75% of surgical site infections associated deaths directly attributable to the surgical site infection. Surgical site infection is also the most costly hospital-associated infection type, with an estimated annual cost of $3.3 billion. It extends hospital length stay by 9.7 days, so almost 10 days, with cost of hospitalization increased by more than $20,000 per admission. So there are several types of antimicrobials, which include antibacterials, antiprotozoas, antifungals, antiparasitics, and drugs such as sulfa and mercury. However, the only category of antimicrobial agent routinely used in surgery is antibiotics. As I mentioned earlier, healthcare-associated infections and surgical site infections are a major public concern. As surgical site infection is an infection that occurs at or near a surgical incision within 30 days of the procedure. Surgical site infections are typically caused by one of 6 types of species of bacteria, to include Staphylococcus aureus, coagulase negative Staphylococcus, Enterococcus, E. coli, Pseudomonas aeruginosa, and Enterobacter species. However, the most causative agent of surgical site infections is Staphylococcus aureus, which is present in the nose and on the skin of approximately 25% of healthy persons. This is why it is imperative that we do not reach over the sterile field if we are not wearing sterile attire, and we don't let anybody else reach over our fields either. Dead skin cells with Staph aureus can fall onto the field. Also, this is another good reason to make sure that we are wearing our masks properly and keeping our noses covered. Limiting the amount of talking at the sterile field is also going to reduce the shearing of dead skin cells and reduce the chance that dead skin cells from our face are going to fall onto the surgical field. As surgical technologists, we have a responsibility to our patients to apply the best aseptic technique possible so that we don't send our patient home with a surgical site infection. Antibiotics are effective tools that can be used to supplement conscientious practice of sterile technique. Antibiotics are used in surgery to help prevent surgical site infections and to treat infections caused by pathogens. Remember, pathogens are disease-causing organisms. Antimicrobial agents are also used to prevent and treat infections caused by pathogenic microorganisms. And it's a common practice to provide antibiotic prophylaxis an hour or 2 prior to surgery. However, antibiotics may also be given intraoperatively from the sterile field in the form of antibiotic irrigation or perhaps an antibiotic ointment. Sometimes the surgeon will also provide antibiotics for the patient to take post-operatively. The Surgical Care Improvement Project, called SCIP, is a partnership developed by the Centers for Medicare and Medicaid Services and the Centers for Disease Control. One aspect of the project focuses on surgical site infections, and one of its goals is to increase compliance for proven effective measures related to the use of antibiotics. Some of those things include the selection of a proper antibiotic, timing antibiotic administration before the incision, identifying the person responsible for those actions, and verification of antibiotic names, times of administration, and documentation. Now, the surgical safety checklist that was developed by the World Health Organization is another tool that facilities can use to help ensure compliance with established standards for antibiotic administration. The checklist is going to prompt the caregiver to indicate if antibiotics were given within an optimal time frame. Now, the earliest antibiotics, such as penicillin, were derived from natural chemicals that were produced by microorganisms. Some examples of microorganisms that produce antimicrobial substances include fungi and bacteria. Penicillium cryosogenum naturally produced penicillin. Bacitracin is naturally produced by a genus of bacteria called Bacillus. Cephalosporin antibiotics are derived from a mold called Cephalosporium acremonium. And although antibiotics occur naturally, they can also be changed in the laboratory to create semi-synthetic antibiotics. So whether antibiotics are all natural or synthetic, they all have the same goal, and that goal is to help the immune system fight against an infection, right? Antibiotics are typically given intraoperatively for prophylaxis of postoperative wound infections. So something to keep in mind. Infectious microbes may come from the patient's own bacteria, which we call indigenous, or outside the patient, which is exogenous. There are also two terms that we need to be familiar with: bacteriostatic and bactericidal. Bacteriostatic agents are those that inhibit bacterial growth. So they're going to stop the bacteria from multiplying or reducing or reproducing. And then bactericidal agents are those that kill bacteria. In order for a pathogen, remember, which is a disease-causing microorganism, to do its dirty work, it must have a way to get into the host. This is called a portal of entry. To cause an infection, that host must also be susceptible, right? If you take a look at figure 5.3 in your textbook, you can see the infection cycle. So source of pathogenic microbe plus transmission route plus susceptible host equals an infection. Surgical site infections are caused by the introduction of a pathogenic microorganism into a susceptible host. As I already mentioned, the source of infection may be indigenous, which comes from the patient, like Staph aureus, or exogenous, an external source, like personnel and the environment. When a surgical site becomes infected, we need to identify the microbe that is causing it so that we can choose an appropriate antimicrobial agent. And some common methods used to identify pathogens include gram staining and culture and sensitivity, which we oftentimes abbreviate as C and S. Now, typically, the healthcare provider will prescribe a broad-spectrum antibiotic while they await the results of the tests. So next, we're going to talk about each of these types of tests in a bit more detail. Gram staining. Gram staining is a fast way to help the healthcare provider prescribe an initial course of antibiotics because it distinguishes different types of bacteria. The bacteria with a thick cell wall is going to stain dark purple. These are referred to as gram-positive. And those with a really thin cell wall are going to stain pink, which we refer to these as gram-negative. So the staining is also going to help identify the shape of the bacteria, and this is referred to as morphology. This is going to give us clues to which antibiotics will kill it. So there are three basic shapes, remember, of bacteria. Bacilli, which is rod-shaped, cocci, which is round-shaped, and spiral, which is spiral-shaped. And you can also see these in your text in figure 5.4. Now, bacteria also arrange themselves in certain ways, and this is also going to help us classify and identify them. They can appear in clusters, which is a staph is the medical, the word part for cluster or group is staph, or in chains, which is strep, or in pairs, which is diplo, or they can appear singly. Gram-positive bacteria are typically going to be cocci, and gram-negative bacteria are typically bacilli. Now, we do find some in the reverse situations, but this is typical. So next we're going to talk about culture and sensitivity. culture and sensitivity is going to begin with taking a culture from the site of the infection. And if you look at the image on the top left of your, top right of your screen, actually, you're going to see a tube and a swab. Now, if the surgeon wants to take a culture intraoperatively, the circulating nurse is going to open up 2 culture tubes for you. One is going to be anaerobic and the other is going to be aerobic. Remember, some bacteria have to have oxygen to live and others are killed in its presence. So one tube is an aerobic culture and the other one is for anaerobic culture. So once the surgeon takes the cultures, then you're going to put the little swab into the tube. You're going to pass those off to the circulator, and those are going to go to the lab. Now, in the lab, they're going to take an agar plate, like the one you see on the bottom right of your screen, and they're going to inoculate it with the culture, and they're going to grow it out. All right? They're going to incubate those plates for 24 to 48 hours, and this process is going to help them to isolate the bacteria that was growing in our wound or wherever. So once it's been isolated, then they're going to inoculate another plate with what they call the pure culture, all right? Then what's going to happen, you can see in this image here on the agar plate that they've placed a bunch of little white discs around the plate. Now, each of these discs is going to be impregnated with an antibiotic. Now, notice that the plate in the image has large circles around some of those discs, and this is because the bacteria is sensitive to that particular antibiotic. So now we know exactly what the bacteria is and which antibiotic kills it. So now the healthcare provider can prescribe the correct antibiotic, the best antibiotic. And because of the emergence of multi-antibiotic resistant bacteria, faster methods are now available so that we can treat patients more quickly. And some of those tests include enterotubes, Vitec, and BBL crystal system. So in order for an antibiotic to be successful, it must have the ability to target specific structures in the microorganism that differ from the host cell. Otherwise, all it's going to do is kill off the wrong cells. It's going to kill off the host cells instead of the pathogen that's attacking the host. So remember, prokaryotes are one-celled organisms like bacteria. They have very simple structures. They don't have a nucleus. Eukaryotic cells are those of multicellular organisms that are very complex, like those of humans, animals, plants, and fungi. So because of the prokaryotes' cell wall structure and their small ribosomes, antibiotics can be designed to target and bind to these specific structures. So now that we've reviewed some of the concepts of microbiology, we're going to discuss antimicrobial action. So this discussion on microbial action is going to include mechanisms and types, as well as antibiotic resistance. Antimicrobial action is the process that the antibiotic uses to kill microorganisms and stop their growth. So if you take a peek at box 5.1 in your text, you'll see a list of methods of antimicrobial action, which are inhibit cell wall synthesis, interfere with protein synthesis, alter cell membrane function, inhibit production of RNA or DNA, and interfere with cell metabolism. So if the antibiotic does any of these things, the bacteria is going to die and it's not going to be able to replicate. Some antibiotics, such as Cephalosporins, penicillins, vancomycin, and bacitracin prevent bacteria from producing proteins, and these proteins are necessary to maintain their cell walls. AMINOGLYCOSIDES, macrolides, and tetracyclines are all examples of antibiotics that interfere with protein synthesis. Other antibiotics, such as polymyxins and antifungals, are going to destroy the integrity of the cell wall, and as a result, contents of the cell are going to leak out. Some fluoroquinolones and some antivirals prevent the cell from producing RNA and DNA that's necessary for cell replication. Antimicrobials are classified as bactericidal or bacteriostatic. Remember, bactericides kill bacteria, and bacteriostatics inhibit the growth of a bacteria. Now, antimicrobials are also classified by their spectrum of activity, and there are 3 of them. Broad spectrum antibiotics have a wide range of activity, and they're usually effective against both gram-positive and gram-negative types of bacteria. Narrow spectrum antibiotics are often only effective against one type of bacteria, like gram-negative or gram-positive, but not both. And then lastly, there's limited spectrum antibiotics, which are only effective against one species of bacteria. So let's talk about antibiotic resistance next. Because microorganisms can replicate really quickly, they often make mistakes. So think about when you're trying to do something too fast, right? Mistakes are bound to happen, and as a result of these mistakes that the bacteria are making, or we call them mutations, sometimes it gives them the ability to adapt to new environments and their hosts really quickly. Statistics indicate that approximately 70% of bacteria that cause hospital-associated infections are resistant to at least one of the agents that are used to treat those infections. Antibiotic resistance, by definition, is the ability of some strains of pathogenic microbes to prevent or withstand the actions of antimicrobial agents. So, as you might have guessed, this is not good. There are 4 major categories of antibiotic resistance mechanisms, and these include microorganisms may manufacture specific enzymes that inactivate the antibiotic. The cell membrane of the bacteria may be altered to prevent the antibiotic from entering it. The target area that the antibiotic is meant to target may be altered so that the agent is no longer effective, or microorganisms may add substance to the antibiotic, which inhibits its ability to reach its desired binding site. So, we can use penicillinase as an example. Bacteria that produce penicillinase, which is an enzyme, have the ability to break down penicillin, which renders it ineffective. So as a result, these bacteria become resistant to penicillin. When antibiotic resistance is discovered, scientists are going to try to go to work to develop new antibiotics to treat the resistant strains. 2 resistant strains are methicillin-resistant Staphylococcus aureus, which we refer to as MRSA, and vancomycin-resistant enterococci, which we abbreviate as VRE. Even more concerning is the emergence of what we call superbugs. Now, superbugs are typically resistant to 2 or more antibiotics, and some superbugs are resistant to up to 6 antibiotics. A strain of tubercle bacillus, which is a bacteria that causes TB, is resistant to several types of antibiotics. Similarly, there's a new strain of bacteria, which is Enterobacteriaceae, which is normally found in the GI tract. It has been identified as resistant to carbapenem, which is a group of beta-lactam antibiotics, which we'll talk about a little bit more later. So sadly, this resistant strain has been found on endoscopes. Even scarier is the fact that resistant strains are occurring at such an alarming rate that the pharmaceutical industry can't keep up. And unfortunately, antibiotic resistance increases patient morbidity and mortality, and currently there is not an end in sight to the problem. One causative agent of antibiotic resistance is the misuse of antibiotics. When normal host bacteria is repeatedly exposed to antibiotics, there's an increased chance that they will develop a resistance. Another common factor is that individuals typically quit taking their course of antibiotics when they feel better instead of finishing the entire course as it's prescribed. This can result in stronger strains surviving, mutating, and reproducing, which could eventually lead to resistant strains. So take a look at box 5.2 in your text. Here you're going to see the major groups of antibiotics, and these include beta-lactams, AMINOGLYCOSIDES, fluoroquinolones, macrolides, and tetracyclines. So we're going to look at each of these in a bit more detail on the following slides. Beta-lactams. These refer to a large group of bactericidal antibiotics. They are similar to each other in that they have this same core structure that's called a beta-lactam ring. Unfortunately, most agents in this class are not effective against MRSA. Resistance occurs when bacteria develop the ability to break down that beta-lactam ring. And to counteract that ability, pharmaceutical companies insert synthetic compounds called beta-lactamase inhibitors. This group includes penicillins, cephalosporins, carbapenems, and monobactams, and we're going to discuss each of those in a bit more detail as well. So penicillin was the first true antibiotic, and it was extracted from mold, and it's available in both natural and semi-synthetic forms now. It's effective against a wide variety of gram-positive and gram-negative microbes. That's a good thing. So take a look at table 5.3, and you're going to see a list of penicillins, which include natural, penicillinase resistant, aminopenicillins, and broad-spectrum penicillins. Now, natural penicillins include G, V, and G-benzathine. The advantages of natural penicillins are that they're going to be low cost and they're typically low toxicity. Natural penicillins are a narrow spectrum antibiotic, and they're typically used to fight gram-positive microbes. Now let's talk about penicillinase resistant penicillins. They are semi-synthetic antibiotics, and these were developed to fight against bacteria that produce penicillinase. Now some examples are nafcillin and oxacillin. Aminopenicillins have an added amino group that makes them more effective against gram-negative bacteria, but they are not penicillinase resistant. There are also some broad-spectrum penicillins, and those are piperacillin and ticaracillin. And these penicillins are effective against Pseudomonas, but unfortunately, many individuals are allergic to penicillins. Me being one of them. So let's talk a little bit about cephalosporins. Cephalosporins are derived from the fungus C. acremonium, and there are 5 generations of cephalosporins, and these can also be found in table 5.4 of your textbook. Now, each newer generation has a greater gram-negative antimicrobial property, as well as a longer half-life. And this means that every so many hours, the concentration in your bloodstream drops by half. So it's good that they have a longer half-life, because this means that doses are needed less frequently. The first generation of cephalosporins includes cefazolin, cefripirin, cefralexin, and cefraloethin. And these antibiotics fight against gram-positive microbes as well as a few gram-negative ones. Now, the second generation of cephalosporins includes antibiotics such as cefoxitin, cephanicid, cefmetazole, cefotetan, so on and so forth. These antibiotics fight against a wider variety of gram-negative bacteria, but they're not really effective on gram-positive bacteria. There might be a few that they're effective on. The third generation of cephalosporins includes a variety of antibiotics such as cefotoxamine, cefoperazone, ceftazidime, and others. And these antibiotics fight against a wider range of gram-negative microbes, but they're less effective against gram-positive ones. They're also going to be used to treat some hospital-associated infections. Now, the fourth generation of cephalosporins includes cefepime, and this type of antibiotic has an extended spectrum regarding gram-positive and gram-negative bacteria, and many of them can also cross the blood-brain barrier. So this means that they can be used to treat infections of the brain. These antibiotics are also used to treat Pseudomonas aeruginosa. And then the fifth and final generation of cephalosporins is a new generation that has been approved and proven effective against MRSA and VRE. And there's only one drug that's been approved so far by the FDA, and it's called ceftaroline. And it's important to note that some cephalosporins may be used as topical irrigation solutions intraoperatively. So let's move on and talk a bit about carbapenems. Now, carbapenems are a wide-spectrum antibiotic that are effective against many gram-positive, gram-negative, and anaerobic bacteria. However, most are not effective against Enterococcus faecium and MRSA. These antibiotics are considered the last line of defense against a number of multi-drug resistant bacteria. And they're also used to treat polymicrobial infections, which are those that are caused by several different microbes. And Premaxin was the first approved agent in this class, but there are some other ones like meropenem and ertapenem and doripenem. So let's talk a little bit about monobactums. Monobactums are a really small class of beta-lactams, and so far as Trianem is the only drug in the class. And this is a synthetic drug that was originally isolated from Chromobacterium violacum, and it has been used to fight infections caused by Pseudomonas. It's also safe to use on patients who have an allergy to other beta-lactams, and it's available for intramuscular and intravenous injection. So now a bit about the aminoglycosides. A list of aminoglycosides can be found in Table 5.5 in your textbook. Aminoglycosides include amikacin, gentamicin, tobramycin, and kanamycin. These drugs are derived from various strains of Actinomyces bacteria. Now, aminoglycosides work by either interfering with protein synthesis by binding to bacterial ribosomes or by creating these small little holes in the bacterial cell membranes, which is going to cause leakage. Typically, these antibiotics are only effective against aerobic gram-negative bacteria. However, they may also be effective against certain strains of Staphylococcus. Major adverse effects of aminoglycosides can include nephrotoxicity and ototoxicity. The most effective routes of administration are going to be topically or parenterally. Fluoroquinolones are synthetic antibiotics, and these inhibit something called DNA gyrase. And DNA gyrase is a protein that is necessary for bacteria to copy their genetic material and then replicate. If you take a peek at Table 5.6, you're going to see a list of fluoroquinolones. These antibiotics are classified as first, second, third, and fourth generations. They also have a relatively low toxicity, and they're considered broad-spectrum antibiotics. They're typically prescribed for systemic infections, UTIs, and osteomyelitis. Many are also used to treat infections of the eye. Some fluoroquinolones include ciprofloxacin, ofloxacin, norofloxacin, enoxacin, levofloxacin, and others. So if you look at Table 5.7, you're going to see a list of macrolides. And macrolides are a group of broad-spectrum antibiotics that inhibit protein synthesis. And the way that they do this is they bind to the ribosomal unit of the bacteria. Macrolides are both bactericidal and bacteriostatic. So they are only partially broken down by the body, and the majority of the medication is secreted in the bile, and most are administered orally. However, erythromycin is available in a topical ointment as well as a solution, and it's commonly administered into the eyes of newborns prophylactically to prevent gonococcal infections. Macrolides include erythromycin, azithromycin, and clarithromycin. The last major group of antibiotics that we are going to cover is tetracyclines. Now, these can be found in Table 5.8 of your text. Tetracyclines include tetracycline, minocycline, doxycycline, and tetracycline. And tetracyclines were obtained from cultures of streptomyces, and they're considered the first broad-spectrum antibiotics. They're bacteriostatic in that they bind with the ribosomal unit, interfering with protein synthesis. Now, some bacteria have developed a resistance to tetracycline, and these include MRSA, VRE, and Pseudomonas. They are primarily used to treat acne and rickettsial infections. A subclass of tetracyclines does exist, and those are called glycocyclines, and these were designed to overcome bacterial resistance. So there are several other miscellaneous antibiotics to consider, which include sulfonamides, which we typically refer to as sulfa drugs, and other individual agents. Take a look at table 5.10 and you're going to see a list of combination antibiotic agents. Sulfonamides are laboratory synthesized chemicals and they interfere with cell metabolism, and the way they do this is by inhibiting bacterial synthesis of folic acid. Interestingly, they were originally introduced way back in 1935, and so this makes them the oldest of the chemotherapeutic agents. Their use is limited today, though, due to increasing microbial resistance. But some examples of sulfonamides include silver sulfadiazine, sulfasoxazole, sulfamethoxazole, sulfasalazine, and sulfacetamide sodium. So there are, like I said, also a number of individual agents. I'm not going to go over each of these in this lecture, but they include bacitracin, chloramphenicol, clindamycin, daptomycin, linezolid, metronidazole, and polymyxin B, and vancomycin, as well as a few others. So be sure that you review the specifics about each of those as it's discussed in your textbook. The last thing that I want to talk about is that there are several antibiotics that are also combined with other drugs that are used to treat specific conditions. One example would be colimycin S-otic. That is a combination drug used topically to treat bacterial infections of the external auditory canal. Cordyceps is also another example. It's a combination of neomycin and polymyxin B, and it's used to treat both inflammation and infection of the ears. So just as it is important to complete an entire course of antibiotics to reduce microbial resistance, it's also important to complete this entire lecture to increase your understanding of antibiotics. I hope that you found it helpful and that I will see you next time for another discussion regarding drugs that are most commonly used in surgery. Thank you for your dedication to becoming the best surgical technologist that you can be. I'll see you next time.